progressively worse. She denied any alteration of eyelid position with feeding, and he had been followed closely by his pediatric ophthalmologist and had previously shown no signs of amblyopia of the left eye.
طيب الكيس هنا بيتكلم عن توزس. هنا ببساطة شديدة الدايجنوزس هنا توزس، وعشان نكون مرة specific we will say that the diagnosis here is left congenital ptosis. Reason why is drooping of the upper eyelid. It didn't tell you the cause, so you tell the finding, and that is ptosis. Now ptosis meaning drooping of the upper eyelid, and the reason there's drooping of the upper eyelid is because the muscle that helps in elevation of the upper eyelid is paralyzed. It could be a case of molar muscle, which is supplied by the sympathetic nerves. And if the molar muscle is paralyzed, that means the sympathetic nerves are affected. And they can be affected like in cases of Horner syndrome, where you basically have a triad of anhidrosis, lack of swelling, meiosis, pupillary constriction, and third thing, ptosis. And the ptosis is due to paralysis of the molar muscle that helps in elevating your upper eyelid. So that could be one possible cause. And of course, Horner syndrome, these syndromes can be joined together as anisocoria, which you have unequal pupil diameter. It's not exclusive to it. You can also see it in the case of oculomotor nerve palsy. So that's one of the possible causes of ptosis. One is paralysis in the molar muscle. Another one is paralysis in the main muscle that elevates your upper eyelid, which is levator palpebrae superiosus muscle, which is supplied by, yes, you guessed it, oculomotor nerve. If there's oculomotor nerve palsy, not only you will have ptosis, but also the patient will have exotropia towards this region. Exotropia meaning divergent strabismus. The eye will be deviated toward this side only. And besides exotropia, the patient will also have mydriasis, not constriction, mydriasis, because the oculomotor nerve is important in pupillary constriction from the efferent and not afferent pathway. Okay? So another cause is oculomotor nerve palsy and paralysis of the levator palpebrae superiosus muscle. Another cause could be facial nerve palsy. I mean, there's also one muscle called frontalis muscle. It can help in this muscle right here. It can help in elevating your upper eyelids. If you have facial nerve palsy or Bell's palsy, you can check by Bell's phenomena, in which basically whenever you sleep and you close your eyes by orbicularis oculi muscle, supplied by your facial nerve, the cornea does not stay in its place. Your cornea actually goes up. And this helps to prevent dryness. But this is obviously a protective reflex to prevent dryness, because if there's dryness, there's keratitis. If there's keratitis, this leads to a corneal ulcer. They call this ulcer with lag ophthalmus. So you'll have an ulcer in the lower one third of the cornea. So this is one possible cause too, facial nerve palsy, which can be observed by Bell's phenomena, where this protective reflex is lost. Instead of during sleeping, instead of the cornea going up, it stays as it is. And you can check by telling the patient to close his eyes, and you check the cornea in its place. That is one possible cause. Another infamous cause is myasthenia gravis. Myasthenia gravis is basically an autoimmune disease where the acetylcholine is attacked by antibodies that leads to muscle being relaxed, not being as strong, and especially myasthenia gravis is characterized by bilateral ptosis, where there's ptosis evident whenever there's fatigability. Whenever you're exerting these muscles, especially by night, there will be bilateral ptosis. Okay, so one possible cause of ptosis is myasthenia gravis, in general due to acetylcholine low. Besides that could be trauma, and it could be congenital. Here in this case we say congenital ptosis based on the patient's age. Of course, differential diagnosis we mentioned, it could be mechanical, could be pseudotosis, where you have excessive redundant skin that make it appear as if there's ptosis, but there isn't. And besides that, there's also examination you would do. It's not investigation, you'll do clinical examination. There are around at least 6 you should know. One of them is you should do the Marcus-Gunn phenomena. And the Marcus-Gunn phenomena is basically, patient has ptosis in his right eye, but when he opens his mouth, he will have his ptosis improve. They call this Marcus-Gunn phenomena because this is a misdirection between the third and the fifth trigeminal nerve supplying the mandible. So that's one you should test as well. Another one is the Bell's phenomena we mentioned before. The other one is visual acuity and visual field. And this is important because the thing that's really serious about ptosis is not the actual thing. You can solve it by cosmetics, but the thing that's actually bad about ptosis is that it can lead to amblyopia. Amblyopia means deterioration of vision because one part of the eye is not giving complete image from its side to the brain. So the brain will ignore that amblyopic eye or this affected eye and focus on the other. So how will it neglect the other eye? It will not receive the signals, or it will not focus in receiving the signals. It will ignore the signals coming from the affected eye. That means there are going to be further lack of visual stimuli to the eye, and there will be further visual deterioration from this eye, and as a result, it will be permanent. We call this amblyopia. And in the case of amblyopia, there can be many causes. The most common cause is occlusion. It could be due to occlusion. It could be cataract, ossification of the lens. It could be a case of a tumor obstructing the eye, or it could be like rhabdomyosarcoma, let's say, or it could be a case of ptosis, which blocks part of the vision, right? There could be other causes like strabismus, like say exotropia or esotropia. If your eye is deviated towards one side of an image, and if it's focused on that one side of the image while the other is normal, then it will also ignore that eye as well. That's why squint or strabismus, eso or exotropia, is quite serious, okay? So you have occlusion, you have strabismus, also refractive error. If you have basically a hypermetropia, basically near visions appear blur, but distant vision is fine, you also have a risk of amblyopia. So typically amblyopia, a lot is serious by that point, and the only way you diagnose it is if you have a child and you measure his refraction, you do his prescription, and you notice that his refraction in this eye, this right eye, is +8, let's say, but the refraction in this left eye is +4. So there's a difference of 2. There's a 2-line difference between 2 refractive errors on the right and the left eye. And that confirms amblyopia, because if you have more than a 2-line difference between the refractive error in this eye and this eye, whether myo or hypermetropia, but more commonly hypermetropic patients with the plus side, then this is a diagnosis of amblyopia. Okay, and the only way to treat amblyopia is by occlusion therapy. You have to patch the normal eye so you can tell the brain to force it to work with the other weaker eye, the amblyopic eye. You basically force it to work with it, and strengthen it. Okay, so you do it by an eye patch, or you do atropine drop on the normal eye, so you can cause blurry vision. So you can force the brain to work with the other eye. I want to focus on this amblyopia because it's very important. Besides that, you check ocular motility of the eyeball, you check the pupils, again, you can check also the degree of ptosis. Regarding the treatment is observation, typically in this child, until school age, because typically ptosis can basically relieve by itself, spontaneously. However, if it's still there, or it's severe, or if it's due to trauma, you'll have to do surgery by that point, okay? And that's pretty much it. Thank you.